Welcome, welcome back, everyone, to our workshops for the cancer care journey on the Cancer Care Symposium. Thank you for joining us this morning. We're following workshop 1 on prevention and early detection with the second stage of the cancer care journey on coordinating the care. But before we start, I want to recognize Texas Oncology as one of our eight different sponsors that we have. They have been working with us, partnering with us for several years, and we're very pleased with their partnership and their support for this particular session. So we have a short video we want to show. It's about 60 seconds. So after that, we'll start right in on the workshop.
Fort Worth, but did you know they're also located in Paris, Uvalde, Austin, Tyler, Bedford, Round Rock, Sherman, Houston, Katy, and more. 210 locations in all. In cities, suburbs, and small towns across Texas. That's Texas Oncology. More than 460 physicians seeing more than 50,000 new cancer patients each year. Delivering about half of all cancer care in Texas. Giving patients access to research and clinical trials, with more than 150 open trials and more than 2,500 patients participating. Leading-edge medical treatment, like breakthrough immunotherapy and combination therapies. The most precise technologically advanced radiation treatment available, including the newest generation of proton therapy. Innovative surgery, like robotic surgery. Treatment close to your home, family and friends, work, and support. More personal, more cost-effective, high-quality cancer care without compromise. That's the difference in community-based cancer care from Texas Oncology.
Great. So let's get started on the workshop 2. We're focusing on innovative coordinated care models. For employees or any patient embarking on the cancer care journey after an early detection, hopefully early detection, the journey is extremely complicated. It's terrifying for the patients, and a lot of it, not just the emotional experience of this, but all of the different providers that they have to see, all the testing that has to be done, all the treatments they have to go through, the different places. It's very, very complicated and very challenging. From the employer perspective, the care that is covered by the employer, we want to make sure that it's high quality care and as supportive for the patient experiencing the cancer care journey as possible. And that really makes the importance of coordinating all of the different parts and moving parts of the care itself to make sure that all of the different people involved in the care itself are working together and making everything, hopefully, process extremely easy for the patient, or a lot easier anyway. So with that, we know that one size doesn't fit all. Every employer is different. They have different workforce populations. They have different locations for their employees. Some are local in one area. Some have employees all over the country or all over the world. So as I said, not a coordinated care model. There are several out there, and probably more than we're showing today, but we wanted to feature 3 just to give you a taste of the different types of models that are available and that you might want to think about. So we'll have, we are very pleased to have 3 speakers. Dr. Leyland Wilfong is a medical oncologist and hematologist with Texas Oncology. In addition to patient care, he serves as the Executive Vice President for Quality Programs and Value-Based Care for Texas Oncology, and as physician liaison for value-based care for McKesson Specialty Care Health. He's a physician leader for alternative pay models, and he's just a very wonderful colleague that we're very fortunate to have as part of our coalition. Dr. Wilfong will talk about a community alliance network of local community oncologists and the team. The second speaker, and I'll introduce right now, so you know what you're in for, is Dr. Rick Watson. He serves as the market medical executive for Cigna in Dallas, headquartered in Dallas. His main responsibilities with Cigna are in the North Texas and Oklahoma regions. facility engagement, total market cost oversight, strategic planning, client sales support, and so on. He's very actively involved in the oncology world, and Cigna has a collaborative care model for oncology. And Dr. Watson will tell us about the collaborative care model that is managed through the health plan. In this case, it'll be Cigna. And our third speaker is my friend and colleague, Lauren Vila, who is the Senior Director for the Pacific Business Group on Health. Lauren works directly with large purchaser members, very large employers of the Pacific Business Group on Health to facilitate collaboration and support their purchaser-driven initiatives impacting healthcare delivery in the U.S. They have groundbreaking work in transparency and accountability, translated into workable solutions for their member organizations. The Pacific Business Group on Health is probably the most pace-setting coalition in the country. And so I'm always so grateful when Lauren shares her information with us so that we can maybe kind of follow in her footsteps or on her tailcoats for the leading pace-setting work that she's doing. Lauren will talk about a network of centers of excellence that they offer to the Pacific Business Group on Health members, as well as other coalition members, including Dallas-Fort Worth Business Group on Health and Texas Business Group on Health, for those employers that are interested in participating, especially those that have employees all over the country in different locations. So that's a taste of 3 different models. There's some overlap, of course, but the whole aim is to have coordinated cancer care. With that, I'll turn it over to you, Dr. Wilfong.
Thank you, Marianne. I appreciate it. So we're going to talk about care coordination in a community oncology model. I'm setting my timer because everyone always complains that I talk too much. So let's go to the next slide. So you heard a little bit about Texas Oncology just a second ago. We have over 460, 490 physicians in 210 locations across Texas. We've been involved in the trials for over 100 cancer-fighting drugs that have been approved. And we're really focusing on community-based cancer care, focusing on quality healthcare close to home is our mission and passion for caring for cancer patients, using evidence-based and value-based care models. You can go to the next slide. So what we're going to talk about, and I've really thought about this from an employer perspective, of how do you define quality cancer care? What outcomes for your employees should you be looking at? And thereby, how do you define what value is for your employee members? Let's go to the next slide. So like this quote, when you get what you thought you bought, meaning that you're spending money taking care of these cancer patients, and are you getting what you think you should be getting for the care that we are providing to your employees? Next slide. Okay, so what we're going to focus on first is the oncology medical home. This was a concept created through a collaboration of community oncology physicians and CMS at the time as a model. Then taken up by the American Society of Clinical Oncology, as well as the Community Oncology Alliance. I serve, in addition to the things I do, I serve as the co-chair for the Payer Reform Committee for the Community Oncology Alliance, and have been very actively involved in developing and creating this model. But this is a way of how do you actually think about what a good quality cancer care program should look like. One is patient engagement. How actively engaged are the cancer team with your patients, and not just at the visit. When they see their physician at the visit, what does that communication look like? But then even after the visit, are we following up with them afterwards? Can they access our clinic when they call, for example, when they have needs? And how do we need something? Are we available to them at their time of need? So that they don't end up having to go to the emergency room or the hospital for services that we take care of them internally. Are we following evidence-based medicine and making sure that we can report and predict on what evidence-based protocols that we are following? And then comprehensive team-based care. Are they getting all of the needs met? When a patient has cancer, there's a lot of issues that they face, not only with just their cancer care. There's psychological issues, there's social issues, family issues, and is the team actually being able to meet all of the needs of that cancer patient? And then quality improvement. It's one thing to say that you're a good cancer center, you're providing care, but I'm sure most of you in your fields know that you can't rest on your laurels. You always have to have a passion for improving the care that we provide. We have an ongoing quality improvement projects that we're finding things that we're not working on and continually finding ways to improve that care as a good quality organization. And then finally, for patients who do not survive their cancer, are we appropriately managing palliative end-of-life care? It was mentioned a little bit earlier, but end-of-life care for cancer patients is really important in making sure that we are providing appropriate care at the end of life for them and avoiding things that are painful, distressing, that aren't going to improve their outcomes. And then finally, chemotherapy safety. We give treatments that are very toxic, and you have to be careful about how you give them. And chemotherapy safety should be an integral program in any quality cancer program. Okay, next slide. So the way the Oncology Medical Home works, it's a collaboration between the Community Oncology Alliance and the American Society of Clinical Oncology. ASCO is the large not governing, but the large organization, very well-respected national organization of community and academic medical oncologists that really helps with education and advocacy for oncology programs. And the Community Oncology Alliance is focused primarily on community oncology physicians, not academic medical centers. So it's a collaboration between the two groups, and the program has on-site accreditation visits to make sure that we're meeting the standards that we just talked about. There's gathering and reporting of measures, again, to prove that we're show that we're maintaining the standards we set forth. An emphasis on pathways. Pathways are ways that we manage cancer patients. And then quality improvement, like I mentioned, that ongoing quality improvement, including patient satisfaction and taking that patient satisfaction feedback and making sure that if you're deficient in an area, that you're improving that area for the cancer patients. And then again, a focused attention on end-of-life care. Next slide. And then the measures and what we actually look at, things that are meaningful to all. ED visits. No cancer patients wants to end up in the emergency room. Nobody, there are a few, but most people don't ever want to end up in the emergency room. And so how do we measure that and continually improve our ability to provide care for patients without them having to visit the emergency room? How do we decrease hospitalizations? How do we make sure that patients are dying appropriately and not dying in intensive care units, getting care that they probably did not want? How do we make sure we're adhering to evidence-based medicine? And then having specific and timely communications amongst the care team and the patients. Focusing on shared savings. Shared savings is a concept where, if there's a cost of giving cancer care, and we'll talk about this in a minute, there can be wide variations in that cost of the care that's provided. And how do we set a benchmark for what cancer care should cost for a particular patient? And how do we make sure that we're managing patients appropriately, that we're avoiding unnecessary costs and avoiding waste and being able to meet those benchmarks, and then sharing in that and the ability of a practice to avoid waste, unnecessary care, and spend the money wisely. And then these target goals are always moving. Like I said, you have to have a good quality improvement program so that anytime you you meet a goal, you need to improve it, and that's just the way we need to think and operate. Next slide. So this Texas oncology approach and how we think about this process. So with Access, we utilize a technology platform to monitor and track the time from a patient's consult or appointment with us. Our goal for our cancer patients is less than 5 days, so that when a patient calls us, that's really the most stressful time for a patient, is from the time they get their diagnosis to the time they see an oncologist and get a treatment plan in place. That, studies have shown, is by far the most stressful time, that unknowing period. And so we need to make sure that we as an organization meet their needs and get them into our clinics quickly, so we can actively manage them and get them past that really stressful time of, you got cancer, to, oh my gosh, what do we do next? And then patient engagement. We have a very active education program for our patients, focusing on shared decision making, so patients know what treatment they're getting, what the benefits and risks of that therapy are, so that they understand fully the decisions they're making about their care. Following evidence-based medicine, we utilize a technology platform, and we can monitor and publish guideline-based adherence. And then we review anything that's off guidelines. There are times when you have to treat patients off guidelines for various reasons. We have a process to internally review that and make sure that we're doing that appropriately. And then team-based care, care navigation is a big part of this. We have regular huddles with our care teams to talk and think about patients. It's funny when you talk to people in the business world, this comes naturally to you that you have team meetings. This doesn't normally happen in the medical world until we kind of force people to. But you have to have those team meetings basically to discuss the patient's care from all aspects, from nursing and pharmacy and social work and the physician and the infusion room and the financial piece. All of that needs to come together to make sure the patient gets the best care available. And then again, the quality improvement initiatives that we have on local, regional, and statewide levels. Our palliative care program, we are implementing something called Serious Illness Conversations, which is a program for people near the end of life to make sure that we understand their goals and values, and that the care we provide helps meet their goals and values near the end of life is really important. And then integrating palliative care into our organization. And then chemotherapy safety, we have very strict policies and procedures around this, reporting metrics. And anytime we have a safety concern, we have a process to improve that. Next slide. And the other big thing about a quality program is importance of transparency. What I'm showing you here is a publication done by the Community Oncology Association about just cost of care in community versus hospital-based practice. And you can see there's a difference in cost. And let's go to the next slide. And what you can see here is the difference in mean cost for patients with cancer undergoing therapy from their total medical cost, highlighted in yellow, of $12,000 in a community versus $19,000 to $20,000 in a hospital-based practice. I show this because that transparency is super important so that you as the employer who's paying the medical bills fully understands what the cost of care is for your patient population so that you're getting what you bought, that you understand what the quality care is and how much you're paying for that, and making sure that your money is being spent wisely by the organizations. Next slide. So one thing that's talked about a lot in cancer care is follow the money. It's interesting when you think about where your money goes. It's not just you spend money, it goes to the payer and then comes to the provider who's taking care of your patient. Especially oncology with the drugs that we give, there's a lot of ways that money is spent and divvied up. I think it's important for a employer to understand this, where the money goes, how it's spent, so that you can make sure that the money that you're spending is actually being given to take care of your employee for their cancer care and not going to other places with waste. And I know Lauren and her group have done a lot of work around this in highlighting the need for employers to understand where their money is being spent. Next slide. So I did talk quite fast, which is unusual for me to finish early. But in conclusion, what I think from an employer to understand is when you think about your cancer care is how do you define what quality cancer care is? It's not always just going to the center that you've heard about. You can get good quality cancer care close to home, and there are good quality community oncology programs across the country. There are good quality academic medical centers across the country as well. But really stepping back and thinking about how do I define what that quality cancer care is? What should I be looking for to make sure that my employees are getting the care that they need? And really thinking about that evidence, that team-based care, the coordination of care, the access, all those things we mentioned earlier to make sure that you're getting that for the money you're spending. And then understanding and being able to track and report outcomes so that you can have shared engagement with your providers. You know, we should, as an oncology group, be able to show you, well, how long is it taking for your employees to get in to see us? What are we spending your money on? Are we following national guidelines? How are we doing with your employees and satisfaction for them? We should be able to report and track that. And then if we have deficiencies, be able to lead to shared engagement so that we can talk about that and ways that we can collaborate together to meet your employees' needs, with the goal to be able to take and manage their cancer care, get them back to work and back to their life, and help them through that. And there's a lot of work that cancer programs, payers, employers can do together collaboratively to improve the care for the patients that we serve. And then transparency around cost, really understanding what are you getting for what you pay for is super important, so that you get what you think you bought. Okay, I think that's it for me. Appreciate it. And I'm going to turn it over to you.
Thank you, Dr. Wilfong. That was very interesting. I'm going to have to spend a little more time studying the follow the money slide. That was pretty interesting. And the other one that intrigues me is the one comparing that cost between the non-hospital based oncology care as in your community model, the oncology home model, and the hospital-based care and Dr. Tim. To be the environment is paying for the very same services across all inpatient, outpatient together. So we'll come back to the RAND study later, but thank you very much for a very, very interesting and informative discussion. Now let me turn this over to Dr. Rick Watson to tell us about Cigna's collaborative care oncology model.
Thank you, Marianne. So what is the payer's role in providing employers a high-performing oncology network? That's what we're going to talk about today. Now, interestingly, you'll see many similarities or even concordance to what Dr. Wolfong has said. So if repetition is the key to learning, all the participants should be well-versed in what it's going to take to have a high-performing oncology network. In full disclosure, there is a lot of similarities there, and that's why Texas Oncology is a participant with us in the oncology focus program. So let's take a look at what all this involves. We can go to the next slide. So in the center, the oncology focus program is based on a few big principles. Number one, we want all of our customers in active treatment to have a very robust care oversight. We're looking at quality measures, we're looking at efficiency measures, and that's, if you're familiar with all of Cigna's programs when it comes to collaborative care, it's always a quality and cost efficiency program. It's not one or the other. And in addition to the fee for service you can get paid, when there is cost efficiency noted, the physicians can actually earn a little bit of shared savings. And that's important because there needs to be an incentive for the physicians to do the extra work that it takes to really take full 360-degree care of an oncology patient. Now, the satellite circles that we have around that center one really talk about the extras that we are expecting through this program. So things like, care collaboration, which we'll talk about in depth. Where are you referring to? Are you staging your cancer before beginning treatment? Are you doing palliative care? Again, very important because like Dr. Wolfong said, people may be getting extra treatments that they may not need or may not want in that. So palliative care, very, very important. And then how are you transitioning care back to your primary care provider or other specialist when appropriate? So let's hit the next slide, please. This is a general overview. We've heard some of this already. Population health management through collaborative efforts with all parties. It has to be larger groups that we do this with. Patient criteria, so they have the cancer diagnosis and are actively receiving chemotherapy, immunotherapy, hormonal therapy for metastatic disease. Now, interestingly enough, we also include people on clinical trials. And in a clinical trial, you may have the medications covered, but all other aspects of treatment will probably fall under the medical cost. So even taking care of those people and making sure that they are having coordinated care is very, very important. And then even those that are on a palliative care regimen with end-stage disease still deserve to be managed because things can go wrong and costs can escalate with them. And like I said, it's a fee for service with a care coordination fee to help support all of these efforts, and then the opportunity to earn some shared savings as well when costs and quality toll gates are met. So let's, next slide, please. So what do we expect generally as the responsibilities for the oncology group? The first thing is they need an oncology care coordinator. This is the person I like to designate or call them sort of the traffic policeman. They're taking all of this information in that we are providing and are disseminating that according to whether the patient needs to be seen, whether we need to get a specialist involved, whether they need different medications there, but whatever they need, this person is taking in all of that information and directing where the patient needs to go or needs to be seen. Secondly, we always ask for a key focus action plan. This is the foundation. where the group has set out what they are going to do. What is the plan that they will follow to help reduce the total medical costs, improve the quality, and then also look at the other activities that we are expecting. Like I said, the referrals, the palliative care, et cetera. What are you going to do around those activities to be successful in this program? So let's look at the next slide. We don't just hand over a bunch of information to our group and say, go ahead, have at it, good luck, hope you're successful. What we do is we support them at every avenue. Now, starting at the right, as soon as the contract is signed, within 7 days, we are having a meet and greet with all of the clinical staff together. So there's familiarity there, and you know where those resources are located. We have a post-implementation call. 2 weeks after the effective date, we're meeting with the group again. Then we hold joint operations committee meetings every quarter. We want to make sure that the group has transparency into what the costs are, how their performance is progressing, and what we can expect in the future. Now, who's on the clinical side for our groups? What are the payers' responsibilities to help the group be successful in this program? Number one, we have an oncology clinical enablement manager. This is someone who assists with the onboarding of the person, the clinical coordinator at the oncology group. So that person coming in knows what reports are available, how to access them, and gets them familiar with Cigna's resources and ways of doing things. Then we have an oncology-focused non-clinical navigator. This is someone who is your single point of contact for the group. So when there is an issue with a bill, with a referral, that group doesn't have to sort of search around and look. There's somebody that can come in and say, hey, I have a problem, help me fix this. And then there's a case manager. So we have oncology programs that help provide services that the oncology group typically doesn't, but the payer does. So things around how to access services, what do your explanation of benefits mean, do you have your follow-up appointments, et cetera. Cigna provides a case manager. We tie in that case manager with the group. So again, familiarity. If this patient is requiring something, the care coordinator at the oncology group can call the case manager and say, I need some help. Let's work together to get this resolved. So lots of resources, not just informational, but also personnel that will help the group be successful in our program. So let's look at the next slide. Quality and efficiency measures. You can go on again to the next one. So what are we looking at as being very important? Again, you'll see many similarities to what Dr. Wilson talked about, but pain and pain management. Number one quality measure that we're looking at, not in terms of importance, but in terms of the list here. Do those people who are having pain, is there a care plan around that pain management? Is it being controlled? Then there's a depression screening and follow-up. We have seen very, very high incidences of comorbid depression in people with any type of chronic disease, but it's especially high in those undergoing oncology treatment. So have you identified those people? What are you doing to make sure they get that depression treatment? Also very important for caregivers, high rates of depression with them. So, Cigna is rolling out a program to help those cancer, the caregivers, the oncology caregivers as well, because we know the depression is very high in that population too. What certifications do you have if you've gone the extra mile to make sure your practice has obtained extra certifications in oncology treatment and care? Are you adhering to the guidelines? Again, then there are national guidelines out there that really point out the best, most effective cancer treatments with the greatest outcomes. So how much are you following those? And we know Texas Oncology does that, and when there is a change from a program, they ask why, because they want their doctors to be following that. Patient experience. Now this is interesting. We may know how the group is doing, and the group may know how they're doing, but do the patients tell them how they're doing? And we want that some people call it that third leg of the stool in terms of value-based care. What is the patient experience like? We want to know, and we want to make sure that the patients are happy and are feeling the fruits of the labors as well. And then what is the patient care plan? Is there a plan for all the programs for shared decision-making that gives people all of the options and enables them to be a partner in their own care rather than being just dictated to what treatment they will receive? Let's keep going to the next slide. I believe now we're talking about the efficiency measures. So again, what are the costs in medical care? Inpatient and emergency room utilization, always high. We have found that the best way to help decrease some of the inpatient ER utilization is just knowledge about the disease. And that's where care plans and things come in. Care plans will tell patients, here's what to look for, here's what to expect. If you have any of these symptoms or problems, call us first. Don't wait. Don't let it simmer until it gets bad enough that you have to go to the emergency room or the ER. So those, of course, top of the list in terms of cost drivers. Now, high-tech radiology, are you sending to the most preferred facilities? Or are you sending them to high-cost or out-of-network places where they can get the same MRI or CT for a much more expensive price, which is what we're trying to avoid? Again, clinical pathways programs, are they being followed? Then we have pharmacy and medical benefits. Now, this is where we have seen the not quite exponential growth, but double-digit medical trend each year in terms of pharmacy and medical medication utilization. So we look at the amount of generic utilization for the pharmacy benefit and putting a baseline in there. Are you exceeding that baseline? And then also the biosimilar or lower cost therapeutic alternatives. Many new medications are coming out weekly for cancer treatment. Tough to keep up with all of them. I don't know how the oncologists do it. I can't. But there are vastly different price ranges for them as well. So are there biosimilars that provide the same outcome at a much lower cost, and are you sticking to those? So again, big time savings there with efficiency in medication. I think we might be stuck. Or is my computer stuck?
No, I am back. And would you like me to advance to the next slide?
Yes, please. Okay, financial model, then keep going to there we go. So what do we look for as sort of the absolutes in terms of if you were to earn a shared savings, what do we consider the most important? The first thing is quality. You have to either have obtained that higher certification or being following those national guidelines with a minimum benchmark, and you need to have an efficiency toll gate. You have to improve by 10%, or you must be above the 75th percentile for inpatient admissions, because we know that is a huge cost driver for you. So you have to meet these toll gates before we would do anything else, before we would look at any of the other measures, before you would earn a shared savings. So go to the next slide, please. Informatics support, my last slide here. These are just an example of the information and the reports that we give to groups to ensure they can be successful. So they will get inpatient and case management referral reports, who's in it, who's been admitted inpatient, et cetera. I mean, when I was in practice, it's probably a little different today because I was back in the Stone Ages, but I didn't know when someone was admitted to a hospital. Only if they were admitted to my hospital, I may find out about it. Now we're giving the physicians that information daily. Has patient been admitted, who's in case management, et cetera. Quarterly, they'll get reports like which patients are in the program, what's your overall improvement in inpatient facilities, how are you doing on ER, observation as well. This is something that can be overlooked. On an inpatient report, you receive that, but observation is a short stay. And the cost can be significant. So we're letting the physicians know, hey, there's even people going in for just short stays in the hospital that are driving up the cost. And then you're getting your pain and depression summary, your NCCN guidelines, as well as your pharmacy reports that tell you about your spend and your utilization. Then quarterly, we give scorecards. This is a baseline scorecard. So how did you do the previous year? How are you doing now in your measurement period? And how are you on path to achieve shared savings? And then finally, at the end of the year, we do a reconciliation scorecard where we do all of the math, and hopefully the groups are successful with all of their efforts. So that's pretty much the responsibility that we believe it is the payers in terms of providing a high-performance oncology network to our clients and our employers. That's it for me.
That was just super good, Dr. Watson. Thank you. And it's really reassuring and really encouraging to hear how the payer side, in this case Cigna, is really getting into the teamwork and the care coordination for the cancer care, and your measures and metrics are very impressive. So thank you for sharing all of that. So now let me turn the mic over to Lauren Vila, who will tell us about Centers of Excellence and the network that the Pacific Business Group on Health has put together. And I hope, Lauren, you'll tell us about a Center of Excellence, how this compares to the other ones, and so on. So this is really helpful. Thank you. Go ahead, Lauren.
Yeah, hi, Marianne. Thanks, and thanks for having me. Let's move forward. I always think the best part of every panel is the conversation, so I'm going to just zoom through some of these slides. TBGH really believes that if we're going to change healthcare, we have to do it not only with purchasing power, which means all the folks in the audience really directing their purchasing dollars in the right way to have good impact in the healthcare system, but also we need policy work, and we need to really work within the healthcare system. In California, we have a really large effort to work with medical groups. So we try to address healthcare in all those ways. That's a little bit about us. Go forward. We have a lot of national members, private and public, but purchaser only. Go forward. So the things that I want to talk about today are, education is really important. I think personalized medicine is something that all employers need more information on right now. But I also think that what's really critically important is to think about patient-reported outcomes. We're going to talk about that. We're going to talk about biosimilar adoption and site of care management, two very actionable items for employers. Really want to get a couple of messages out about that. And then, yes, talk about a Centers of Excellence. TBGH, as Marianne said, has been involved with the Centers of Excellence program for a number of years as part of our ESON program. That program, we are now moving on to the next generation of that program, mostly about musculoskeletal changes, moving to a more regional program. So we are no longer a part of that program, but I will talk about the model, which we helped design, which I think is a really sound model. Okay, next slide. So patient-reported outcomes is the next generation of measurement. And Dr. Watson and Dr. Wilfong both did a really great job of outlining how important it is that we look at the outcomes, critically important. TBGH is a really big proponent of moving to the next generation of that, which is how is the patient reacting to all this? Patient outcomes does not equal patient satisfaction. That's important too, but it's not how did the patient perceive their care. It is, when did the patient stop throwing up? When did they go back to work? When could they walk down the stairs by themselves? When could they, these functional measures. And so there are a handful of actually, there's basically one huge national demonstration pilot. We've been involved with it from the beginning around developing cancer outcomes, patient-reported outcomes measures. And I'm happy to talk about that more, turn you on with the folks at TBGH who are running that initiative, which is not me. And it's a really important body of work to have meaningful measures that count for the patients. Next slide. We kicked off an initiative this year where we're actually capturing, in partnership with our employers and on behalf of our employers, measurements, performance metrics from plans. So we have all the national plans as our partners on this project. And the reason that we call it our Playbook Initiative, and so this is our first year, we've learned a lot, we're really getting a lot of good information. Our employers have said to us, we need to all come together, and so here's a skinny set of metrics that we agree are important, and we would like for the plans to report to you on our behalf so that we can systematically track performance, but also look for interventions, look for opportunities for partnership together, and it just lightens the lift for our employers. So it's been a really good initiative. Next slide. The metrics that are in the playbook include two that are very relevant to oncology, and those are the two I want to talk about today. Biosimilar adoption and site of care. Okay, next slide. So, okay, this is a crazy slide, but bear with me on this. First of all, a little bit of an introduction to biosimilars, as Dr. Watson already gave. So the notion about biosimilars are really our hope for competition in the specialty drug space, and we desperately need biosimilars to be successful in the specialty. Unlike small molecule drugs, these are not manufactured molecules, so they are not exact, so we don't call them generics, but rest assured that the FDA has said that biosimilars are no clinically different than their reference product. Also, rest assured that biosimilars have been used in Europe for many years very successfully, and biosimilars are being used right now in this country in a very big way by the VA and also by Kaiser. They are not being used to the degree that they could be amongst our PPO world. And to the chart that Dr. Wilfong showed earlier, it's all about the money. And this is what I want the purchasers in the audience to hear this. So there are biosimilars that are now in the marketplace, many for cancer and two for Remicade. That's actually changing very soon. But we're really focusing on cancer, although I do want to say something about Remicade. So here's what's going on. These are the coverage policies of the 4 national health plans, okay? Aetna, Anthem, Cigna, and UHC. And this is the coverage policies as of now. It changes often. But in a nutshell, when oncology groups like Dr. Wilfong's group wants to prescribe a drug for Medicare, they can actually prescribe. There's no pre-authorization for Medicare, so they don't have to be instructed what to do. So we can say to that group, wow, for your Medicare business, you could actually direct. Remember, these oncology groups are buying and billing these drugs. Okay, so they're the ones buying. So their volume discounts are actually based on what they buy. But when it comes to the commercial patients, what they can actually administer is directed by the health plans. Now I'm showing the 4 nationals, but every single regional health plan has the same setup. Those drugs get pre-authorized, and the health plan has a coverage policy that those oncology groups must adhere to. So the complication with this is a couple. One, the oncology group then does have to inventory and manage a bunch of drugs, right? Because they have to meet the needs of the health plans, and the health plans have different coverage policies. The health plans' coverage policies are based on what they can negotiate on your behalf with the manufacturer for discount is called a rebate. I'm going to say something to you that I say to everybody. A rebate is not a discount if it does not come back to the purchaser. A rebate is not a discount if it does not come back to the purchaser. If the rebate stays with the health plan, you have to be very mindful that it might be creating an incentive for the health plan to identify and select and prefer higher cost drugs. So every single employer in the audience today should look at their drug spend in the medical benefit, and they should ask you're either getting the rebate or to show them what the rebate is that is being used elsewhere. The health plans will tell you, which I'm sure is very true to a degree, that they are using these rebate dollars to lower your administrative fee or to help bring you better services and all that kind of stuff. Totally cool. Ask them to reconcile that for you so that you know, because remember, you are not getting that discount on that drug unless the rebate is somehow coming to you, and you have a right to know where that rebate is and what it's being used for. All right, enough said. I want to point out that go back. This is really an important slide. These are the coverage policies right now. What does this mean? I'm going to say to you that the green, whether it's light green or dark green, you know, we can have a debate. The dark green is that all biosimilars are preferred, period, end of story. Use a biosimilar is what the health plan is saying. Okay, that's the dark green. The light green is saying that the biosimilars are at parity with the reference drug. Use whatever, you know, anything can be used. That's good too. So I'm going to say light green, dark green. That's good. Yellow is one biosimilar is preferred. Okay, what's happening when one biosimilar is preferred? Many of these cancer drugs have multiple biosimilars. What's happening? When one biosimilar is preferred, it's because on your behalf, the health plan has negotiated a really good deal with that one biosimilar. I did have an oncologist say to me, wow, we never really had rebates in the oncology space to the degree that we do now. Now that there's competition for these drugs, bunch of rebates. That's not bad. Remember, rebates are discounts if they're coming back to the purchaser. It's only bad if it's creating an incentive for the higher cost drug to be used so that there's a rebate. You know, as Dr. Wolfang said, there's money going everywhere, right? That's when it's bad. So I personally am concerned that this rebate business that we're seeing come into the oncology space is actually going to increase the cost of all drugs. It just keeps the price high for everybody. The rebate system is very, very broken. Anyway, the red here is where the reference product is actually preferred. Where you see red, please talk with your health plan and say, gosh, you know, this is where I know you're getting big rebates. Let me know where my rebate is or how it's being used. You want a reconciliation. I am going to tell you though right now, these are the cancer drugs. If we had Remicade on here, there would be red in every single box. Okay, Remicade is a bad situation. Those drugs are not being, the biosimilars are not being, ask your health plan. And one of the boxes for Remicade, but Remicade is a bigger problem. Cancer is a problem you can see for some. Cheers to Cigna, who happens to be on this panel and is also has a really good biosimilar policy for cancer drugs. All right, next slide. Ooh, sorry, I had to get that out. It's really an important thing. I do want to talk about site of care. I'm talking very fast so we can get through this. Site of care. You know, big opportunity. Cancer is difficult. I'm not going to, just lots of good examples of moving folks to better site of care, saving a lot of money. Next slide. Because I want to say a few things. Okay, the Center of Excellence, we really believe it's important to align a Center of Excellence benefit with the other benefits that you have. So we've done these vendor integration type of programs with Centers of Excellence to make sure that the Centers of Excellence is well coordinated with all of the programs. And I do want to back up and talk about the Center of Excellence program. Unlike the domestic traveling hip and knee program that we were involved with, Center of Excellence for Cancer is not about having people travel to get their treatment. It is about tapping into a center because people want to be home. They need to have their support group. The nature of cancer treatment is that it goes on for a long time. We don't want people traveling for that. However, we do want to have a Center of Excellence engaging with the treating physician. We actually, I'm very involved with the Community Oncology Alliance that Dr. Wolfang is involved with. That's how we know each other. I feel like they comes, but the problem is that the variation in cancer care across the country is not always that. And so having a Center of Excellence partner with the treating oncologist can assure an employer that, in fact, you're getting some oversight of what's going on with the variation, especially national employers who have employees everywhere really have to think about this. they're really overseeing a lot of, the personalized care is complicated. It's changing always. Having somebody oversee this and partner. We've heard good things from oncologists. They enjoy having this because it's really tough to keep up with all of the latest. Drug choice. I mean, there are disincentives out there. There are disincentives. So the cancer, the Center of Excellence can help assure that drug choices are aligned with what makes sense, best outcomes, best value. And then last, of course, to assure that palliative care is being implemented well and early and as appropriate. Next slide. We also have run patient folks and patient groups. And I just think that the most important thing is to hear what we heard from some of the patients at one of these companies when they said, it's like you've gone to a new country and you don't even speak the same language. I mean, as we said earlier, these people are scared to death. It's complicated. There's so many options out there and there's so much information, which is awesome, but so much information to filter through. Having an entity, a benefit that they can refer to is so valuable for these folks. Next slide. And so this one builds. Can you go to the next one? This is really what the employer is looking for, right? They want sustainable costs. They want to know, they want transparency. They want to know that outcomes are being measured. They want to know what the outcomes are. When you have employees all over the country, it is really tough to get a handle on all the cancer care that's being delivered. And it's also a highly sensitive area. And so it makes sense to have a partner helping you do this. We are not taking care out of the community. We are partnering with the community to provide accountable and appropriate care. Next slide. I think that might be it. And so that's the concept. We are not taking care out of the community. We're working with the community providers. Next slide. And there's some data citations that help validate the thinking behind our model. Next slide. Okay. Woo. All right, Mary Ann, I'm sorry, I talked very fast. I wanted to get through it all. Done.
Wow. What a marathon this has been. Thank you very, very much, Lauren and Dr. Wilfong and Dr. Watson. This has been so informative. I don't see any questions in the question box. I think everyone is like me. I've got a gazillion questions, but I need to process all of this powerful information and useful information. So those were the three models. I love the one you showed, Lauren, about the comparison of the different health plans and using the reference drug versus the biosimilars. Rick, thank you for your work with Cigna and all the, I saw no red circles around there for preferring the reference drug over biosimilar. So that was a good thing. And then the fact that the Centers of Excellence, that Pacific Business Group on Health has this very large network of large employers working with the local communities is really important. You all have wonderful collaborative models. This is very informative. So I want to thank all of you for participating in today's workshop 3 on coordinated care. It's hopeful and encouraging, and I think we kind of have a guideline for the way forward. Everyone, the next session, workshop 3, will be on survivorship and caregiving issues, and as well as return to work, and that will be on November 17th, and that will be at 11 o'clock to, double check the time here, 11:30 to 1 o'clock. It will be another very powerful, interesting workshop. We will send you reminders. Feel free to share the information with your other team members and register as well. Thank you again for a very informative program.
Mary Ann?
Yes.
There was a question directed to me that I wanted to make sure that it got answered. Some other people may have the same questions, but there's a question from Ashley that said, does the Cigna model allow for fast track for approvals or the removal of prior auth? And I said, we don't have removal of prior auth, but all of those different points of contact help speed through referrals and get them done in a timely manner rather than having to wait. They asked if there do self-funded employers need to buy up for participation in this program? Actually, no. There is no buy-up for participation. The employers do pay a small fee just on the people who are actively receiving the treatment and are in this program. So the couple dollar care coordination fee would be the only charges they would see every month. And then how do employees find out about the program? Employees don't receive official notification of that they're participating in it, but what they do see is a much more coordinated approach to their care and a tremendous amount of support, both from like the care coordinator at the oncology office, as well as all the support people, the case management that Cigna has. And what we do is we're measuring that patient experience to ensure that all of those different interactions are creating a positive experience and bearing fruit for those efforts. So I just wanted to make sure that got answered for Ashley.
So I appreciate that add-on and clarification. So thank you again. If you all have questions, send them to us and we'll forward them to our speakers as well, if it's specific to one of the presentations. So we'll be happy to do that. Recordings will be available, so feel free to go back and review. And also a feedback survey will be sent to all of you attendees, and we hope that you will give us great ratings. With that, thank you again. We'll see